Good morning, good afternoon, good evening, section 4, week 4. It's been a long day today, guys. I hope this week 4 wrap up finds everyone doing well. Just again, going to go through some of the things that were important this week. I thought you guys did a better week. Some of you guys are really digging in and getting into some good information and sharing and exchanging a lot of good stuff. Continue to bring literature to help support some of your thoughts. Certainly it's okay to bring in your clinical reasoning and clinical judgment based on your experiences, but do try to draw from the literature. Okay, so that maybe what you thought and what is supported may not be the same, and it's important to be able to differentiate that and to even say that, say like, well, I know the literature says this, but I've had good results doing this. There's nothing wrong with saying that. But again, being aware of what is out there and being aware of how your treatment approach may differ from what current best practice is or current literature. And there's nothing wrong with you challenging that, but just be aware of that. Also, make sure, again, there's some people who still are just posting on Saturday mornings. And gang, I know we're all busy, but I can't have that. You guys got to be checking your posts as on at least once a day to make sure everybody's getting their questions answered and that dialogue is taking place. Okay, so I'm going to do it a little bit differently because you don't need me to review the articles. I feel like some of that's a little bit just me reviewing stuff. So I wanted to pick out a couple of good discussions that I thought were really important. In Alpha, Harry Koester talked about patellar taping, or I was challenging him a little bit on patellar taping, and we had this dialogue. And I think I shared this article with a couple of people, but the article essentially was looking at taping medially, taping laterally, and taping just right down in neutral. And research shows that it really didn't matter. Everybody got better. And so do we really know what is happening what is happening? Unfortunately, I should say when we tape, not what we tape. Do we really know? And are we really altering the biomechanics, or are we changing? Is it a neuromuscular thing or a proprioceptive thing that we're changing that alters the nociceptive signal that our brain determines as pain? Are we just altering that? I with Harry, I told him, I'm like, this is like palpatory diagnostics with the lumbar spine. We used to think that, an upslip, a sacral torsion, an innominate rotation, whether it be an anterior innominate or posterior innominate, were things that were actually literally moving, and we've recognized that that's not really happening. And perhaps that's what's happening with taping. A lot of people like to tape. I saw that in a lot of the different articles, but why the tape works probably has less to do with mechanics than it has more to do with altering the nervous system. And Bravo, Cheryl had a really good assessment of what's happening in the Dial article in regards to cost saving. And she points out that total knee costs are 10 times, or this physical therapy treatment is 1/10 of a total knee treatment, with the number needed to treat, which was very good, at 7, meaning to get one good outcome you need to treat 7, and anything typically for a number needed to treat, anything less than 10 is considered to be pretty decent. Even though that doesn't sound decent, it is still pretty decent. And she raises the point where if surgeons knew this, would they be more willing to refer to physical therapy? Or when you have skin in the game, a financial skin in the game, whether it be for injections, and we know they like to do injections, or surgeries, are they going to be more willing to keep them close? I see, when all you have is a hammer, everything you see is a nail. And I see lots of PAs who love to give injections because that's all they've got. And I see lots of surgeons who operate because that's what they've got. They also like to give injections, but funny, we tend to go to the area where we can make the most money. I wonder why that is. So be thinking about that as we educate our patients about the benefits. There's going to be an article that came out that's in PTJ. It's early to release, done by Childs and Julie Fritz, about booster sessions. And I'm going to send it out to everyone. It's really good and makes everybody kind of think where we should be going. And interesting how manual therapy versus just traditional exercise. So you guys have to check that out. In Charlie, Tim Garner discussed discharging a patient and keeping them for life. So this really had nothing to do with what we're talking about this week, and yet from a professional standpoint, it has everything we have to do. I love that idea. Tim must be, I didn't see, but Timmy must be in private practice, because that's how private practice people think, as people who are constantly trying to build relationships. And it shouldn't just be in private practice. This should be at hospital-based systems. This should be anywhere. This should be at the VA. This should be anywhere where you're interacting, because no matter what, whether you're dependent on revenue that is built on kind of volume, or you're just dependent on revenue where you're just treating patients and you have this nice little physician group that refers to you, relationship building is critical, because it helps drive the that placebo effect. That was something Sarah Lauer, I mentioned in my response to her. She had referenced that that the placebo, that maybe that some of the treatment effects that we've done are placebo effect. And I'm like, don't be embarrassed about the placebo effect. It is real. It is powerful. You can harness the placebo effect and make it yours and your patients, because perception is reality. If you believe it to be true, it is. And if that gets somebody out the door in 2 or 3 visits and thinks you're great and comes back to see you the next time and keeps them out of the surgeon's office for needless injections and medications and surgeries, then by God, why wouldn't you? I give a talk about the words we use, and we talk about placebo, but we also talk about nocebo, negating the nocebo and emphasizing the placebo. And there's nothing wrong with that. And so building patient relationships is what we do. I don't think we should ever discharge. The whole concept of discharge is so archaic and such a waste of time. Who discharges? Why would we discharge a patient when they're done with their care, they move on? We don't discharge them. We shouldn't be. I think discharges are a total waste of time. They're a waste of just paperwork for paperwork's sake. Outside of maybe work comp, some kinds of legal situations, they're just a total waste of time. But I like the idea of building that relationship for life. That was good. And then lastly, Zach talks about working into pain. What is the best approach? There was this dialogue between Mark and Zach about pain and oh no, I'm sorry, it wasn't Mark, it was Brian. Between pain and is it good to push into pain? I do think we need to. I do think the way I view pain and working into pain, whether it's with manual therapy or with exercise for that matter, because we know that tendinopathies can hurt and it's okay. But when we stop, the pain needs to stop, right? You need to be able to get up, and within a couple of minutes that pain needs to resolve. And if it doesn't, that's a problem. If you continue to have pain, whether it's in exercise or manual therapy that lasts longer than 10 or 15 minutes, you've overdone it. I explained this to the patient. We don't want to overdo it, but certainly the minute you have pain, we don't stop, right? Because our brain has to understand that sometimes pain's not a big deal, and we don't need to all freak out about it just because we get a little bit of pain. However, we don't want to create a nocebo effect, getting back to that, where they're so terrified of the pain that then it limits their mobility, it limits their efforts, and it causes them to doubt what you're doing, obviously. But I did like Brian's idea that, pain isn't always a bad thing, and that the brain needs to understand that pain is sometimes okay. Okay, so moving on to week 5, lateral knee structures, ligamentous disorders. So you're getting new groups. Check your assignments, please, 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 please. I'm going to post. This time I'm going to post them where I post the week 4 wrap up, so that they'll be there as well as part of the attachment. Maybe I'll put them in Dropbox for week 5. Review the group project. Make sure you're connecting right away with your groups and digging in. Again, tackling ligamentous disorders, lateral knee. Continues to check your posts daily from Thursday on to Saturday morning. Midterm grades. I'm going to try to get midterms out by Wednesday to everyone. I got the fit projects that I got to work on, but I'll be trying to get those grades out by Wednesday. Contact me with any questions. Don't hesitate to communicate. I will always respond, and I try to do it as quickly as I possibly can so no one's left in the lurch. Hope you all are well. I look forward to reading your stuff, but again, be mindful that this is a change-up week for week 5, and that you gotta get with your peeps so that you can get on with your group project. Take good care. Have a great rest of your weekend. Bye-bye.